Here we are. Recording will start soon. It looks like it started. All right, I'm going to continue, and we're going to start with blood clots, and then we'll get to the heart, and then we'll get you out of here as expeditiously as possible. Platelets. Platelets. So, as you can see, it's called a megakaryocyte. This is specifically this sort of mega cell. And remember, the anatomy of the bone marrow has a lot of reticular connective tissue. It's like a strainer. It's like you push something through a strainer, little pieces come out, and big pieces stay in, so to speak. Okay, and this is so really what it is it's not a cell. That's why they call it a formed element. It has a lot of membrane, and inside it has a lot of effectively protein granules that contain the clotting factors. So as you can see, the chemicals that are involved are all part of this. Serotonin, okay, plays a role that tends to typically constrict blood vessels. Calcium, which is sort of the mediator, and you're not going to have to memorize the clotting cascade. I want you to know about it. A variety of enzymes that are part of the clotting cascade. ADP as an energy support, and this is very interesting. The PDGF, platelet-derived growth factor. So a word about that. This is when you start, okay, injections of platelet-enriched plasma have become relatively common in athletes. And the idea is that the idea of the platelet enrichment is to provide this is a growth factor. One of the many agents whether it's nerve growth factor, platelet-derived growth factor, we use a lot of these things in healing because now we're beginning to understand them better. Again, we were starting to hear about this for the first time, not a whole, maybe slightly less than 40 years ago, with these growth factors. When we start, and that's really when the science of wound healing and its usage in orthopedics is even less so, probably in the last 25 years. With this, this injections of platelet-enriched plasma to avoid surgery or as an alternative to try to repair cartilage in knees, things like that. Very interesting. And what they do, as you will see, they basically start a plug that helps seal breaks in blood vessels. Okay, and they're inactive. They're inactive and mobile. Nitric oxide plays a role. And nitric oxide and prostacyclin, a kind of prostaglandin, one of these local mediators. The vessels are constantly, there's pressure on these vessels all the time. That's what your blood pressure is. It exerts a push. That push induces the secretion of these factors that basically keep platelets inactive. There's a lot of things that you will see activate platelets, but certainly if you don't have these factors, they're going to be active and it's going to clot inappropriately, which we don't want. Clots are not good. Clots form from turbulence. Clots form from irregularities. And it's got to be smooth. It's like a tabletop here. Completely smooth. It's not supposed to adhere to things. When things are there that are abutments in the way, as you roll things, I do it 1,000 times. When you roll things, it's supposed to just roll. The minute it hits something, it's a potential obstacle. And that's bad. And when it hits that obstacle, they slam together. That platelet aggregation is that's what this is all about. So you're going to see a lot of these things that are part of it. And really the mistaken notion, if I have anything to dispel, is the idea is that, most of our blood clotting occurs when we hurt ourselves. Okay? Again, totally incorrect. The vast majority of the clotting is from what's called the intrinsic system. The intrinsic system is effectively roadway repair, and the roadways are your blood vessels. They're like any other highly trafficked area. They are subject to air breakdowns, small irritations, linings, mini blood vascular potholes, for lack of a better way to express it. How very Pennsylvania of it. We're a pothole nation. And because of that, those defects are constantly being repaired and reopened. That's the beauty of this particular system. So that's the introductory nugget. I don't go crazy about where this comes from. There's the agent is called thrombopoietin, not a big deal for us. So this line is the myeloid line. Again, myelogenous ones are like neutrophils, basophils, eosinophils. This is in that category. Mitosis occurs, but no cytokinesis. So you get a giant cell with all sorts of stuff in it, and then these tiny fragments break off. Okay, and the platelets don't have a large lifespan. And typically, if you go back, and I'm not going to cook in I forgot my password. I'm not going to put in my blood test again, but all of them said platelets. They typically either say platelets are adequate, and this is typically the number. They may give you an absolute number. Any of these, if it's anywhere between these, doesn't matter. It's a pretty wide range. Interestingly, when my dad didn't survive heart surgery, they used a lot of platelets, apparently, in that. I'm unfamiliar with it. He had open heart surgery back in 1988. And that was, and whenever I talk about my dad, I have to reflect back because he died. I was barely 37 years old. So it's more than half my life ago. And I remember they needed someone as a platelet donor. They wouldn't take me because I had been exposed to hepatitis B when I was arrested. Not that it was before I had mounds of transfusions and things like that were there. So that interestingly, that was my cousin became the donor. You're just replacing the bank. And here's what I mean: it gets so large in these little fragments, and those are the platelets. So we can look at them. Those are the numbers, useful. Mostly seals small tears in blood vessels, and really they're the linchpin of blood clotting. And you're going to see there's two pathways. The intrinsic pathway, which is slower and is engaged all the time, again, healing those intravascular roadways. And the one that's used, hopefully, very infrequently is called the extrinsic pathway. Extrinsic means the factors are not found in the bloodstream. They enter the bloodstream when there is tissue damage. Okay, and this damaged tissue factor, which has, you'll see the specific names. In the old days, we called it tissue thromboplastin or tissue factor. It bypasses a lot of the steps, so it clots rapidly. That's and effectively the implication is large defects. Two systems, the distinction between them, very, very important. So hemostasis, slowing. Stasis means to stop, or to slow, in this case, to stop. And so what happens when there's an inch, this is more what happens in the blood vessel, though it could happen anywhere once that the damage occurs. The blood vessel inherently spasms. So what it does in response, it narrows. It's almost think of it as almost a reflex response to limit the amount of blood that's going out. The platelets form a plug in the defect, and then from that plug, it initiates the coagulation or the clotting cascade that occurs. So they respond to the injury, the vasoconstriction. It can be direct injury to the smooth muscle, chemicals that are released when one of these defects occurs. Pain does it. As you might guess, when it occurs in tiny blood vessels like arterioles and venules, the larger the blood vessel, a bigger problem. And most of us, when you've gotten a cut that's bled a lot, it's typically a little bit larger blood vessel. It doesn't stop that easily. Other than for a really bad injury, remember these words: pressure stops all bleeding. And understand, pressure is sustained pressure. So, I mean, you're taking, whether it's on you or somebody else, because a lot of people are just, I can't hold on me. I can't think about it. They have, the side of blood, boom, they're going down. You got to put firm pressure, preferably anything you got handy, paper towel, anything, regular towel, and you hold it over that thing. And I'd say you should by the clock. When you say 5 or 10 minutes by the clock, it's a lot longer than you think. Try to do that yourself. I got to hold this in place for 10 minutes. When you say, that, without looking at a stopwatch or anything like that, when you lift your hand up, go, this must be 10 minutes. It's going to be, you're lucky if it's 5. Time goes very slowly when you're doing things like that. Same thing, if you get a bloody nose, you're supposed to push it back like that. Just see little first aid tips that will help you. And the whole idea is significantly reducing blood flow. Typically, what causes it is collagen fibers. Underneath every lining cell is some kind of loose areolar connective tissue. Okay, part of that, what we call the basement membrane or basal lamina, which is the start of it, has collagen. If there's any defect in those endothelial lining cells, those simple squamous cells, guess what? Collagen is exposed. And so it slides along if it's not exposed, but prostacyclines and nitric oxide help it prevent it from sticking. And this is an interesting one. It's called von Willebrand's factor. Helps to stabilize that adhesion. So von Willebrand's disease, a very interesting clotting disorder that doesn't show up on the basic tests. I'm sure they do the same thing they did forever. Basically, when you're going to have surgery, they do a couple of generic tests to determine whether you are likely to be a bleeder. Pretty standard procedure. If there's unknown whether you have a bleeding tendency or not. That screens out about 99% of all tendencies to bleed. And that my first wife found out that she had a variant of von Willebrand's disease, that they didn't produce this particular chemical to stabilize that, and that occasioned her back in '81 to have a transfusion, which, because the blood wasn't screened, most likely I think that's what she was exposed to hepatitis C. Moreover, ever since that time, you might remember telling you that she has to have a dental extraction, have to have a surgical procedure. They have to give her that DDAVP, that genetically made vasopressin, antidiuretic hormone, because that will, one of the mechanisms when it's given, it tends to increase your clotting, as it were. It's a compensatory. Interesting. There's a lot of variations of von Willebrand. So when activated, the platelets swell, they get sticky. The ADP plays a role. Serotonin and thromboxane A, another one of those prostaglandins. Increases serotonin, particularly, basically induce more to happen. This is the positive feedback. Remember, blood clotting, positive feedback means self-amplified. It keeps doing this until the clot forms and it's secure. So again, there's certain things. It's the event. We see positive feedback. We see a lot in female repro, particularly childbirth, but there's also that plays a role when we get down the road toward the end of the term with menstrual cycle and other cycles that have aspects of that, particularly in female repro. This is positive feedback. Platelets stick, release more chemicals, more stick, until finally secure. So again, it's reinforced. The platelet plug, as it begins to form, the clotting cascade takes the fibrinogen protein, small amount, in your bloodstream, about 4%, out from soluble to insoluble, and then we begin. So for larger tears and larger vessels, or when there's an injury, that's when we see an abundance of these fibrin threads. And basically, I know I'm weird. No comments. But I mean, this is what they told us in medical school. Well, next time you cut yourself or scrape yourself, watch it heal. And you watch it when the clot forms, and it gets kind of gooey, and then it begins to sort of harden and dry. Those are all the stages of healing. This is what's mirrored here. So all of this, it goes from a liquid to a gel, and then finally it firms up. And so, again, the clotting factors we do by Roman numerals. Vitamin K is a big player in all of this. And here are the phases: the vascular spasm, the platelet plug, platelets release more chemicals, and then finally the coagulation occurs. So vascular spasm, plug formation, here, and then finally coagulation. Why this is important in this particular instance is when we begin to think, this is the mechanism when we talk about blood that clots secondary to arteriovascular disease. If you want atherosclerosis, hardening of the arteries, what diabetics get is small vessel disease. And what happens if you go back and think of the linings, again, if you have basically something in, let's say, a tiny arteriole, you have a relatively thin amount of, light amount of muscle tissue out here. You have the endothelial lining, simple squamous cells, just to draw a few of them. And kind of what transpires, my kingdom for my other marker, I got it. What happens is we begin to see deposition of fatty materials that are circulating in the bloodstream for whatever reason, whether they're associated with diabetes, whether they're associated with hereditary problems, whether their lifestyle, whether their diet, whether the absence of, you pick one, absence of exercise, smoking, in that subendothelial area is where we begin to see accumulations of these fats. They cause secondarily, paper towel, don't leave home without it. So what happens is that area underneath begins to bulge a little bit, and we begin to see defects and more spaces, so to speak, between the lining cells. And that's where we begin to see the clots form. Now we're exposing the collagen, and it becomes an inflammatory process. That's why one of the ways we inhibit platelet aggregation, and this is what happens with open heart surgery patients, and maybe they use it for help for other patients. They don't do necessarily as much open heart surgery. I don't know that they do this for stents. Back in the open heart days, they'd have the person take a baby aspirin a day. That's sufficient amount of aspirin in your bloodstream, and aspirin stops platelet aggregation. And there's lots of things that are like that. Like when somebody goes in for surgery, you're very cognizant of the problem with bleeding. So understanding their history, doing the appropriate tests to look for any irregularities in the clotting mechanism, and other things have to do with, okay, don't take any non-steroidal anti-inflammatories. They can inhibit clotting. Don't take any, one of the concerns, a lot of people will take fish oil supplements, which are rich in vitamin D and vitamin E. Very good stuff to take. Unfortunately, you tend to bleed more rather than less. So you get a lot of instructions from the operating room. And if you end up working in a field like this, you're going to see that. So you want to make sure folks are not doing this. Okay, what have you, 10 days before, you got to stop this. It's really important. Okay, it's really important that you tell people and you document it. And then, because, hey, if they don't comply, it's on them. This thing about horses and water and drinking comes to mind. Horse, water, drinking. You heard that one. Yeah. All those neat little sayings work. Okay, so the two pathways, intrinsic and extrinsic, triggered by tissue damage, that's the extrinsic, series of procoagulant. The intrinsic also, but the tissue damage is much more specific and finite. And I'm fond of saying this, all roads lead to factor 10. It's just the roadway on the extrinsic theory is one step, and the roadway in the intrinsic pathway is multiple stress. Factor 10, and you're going to see calcium playing a pivotal role. There's a platelet factor, and they form what's called prothrombin activator. And the whole ball game, we're doing virtual event, I'm right. That prothrombin activator is a catalyst. It's always a series of catalysts. That's what they are. Proteins, catalysts, that triggers prothrombin, again, the pro, inactive, because it was active inappropriately, our blood would clot like crazy. Prothrombin is catalyzed to thrombin, and the thrombin is then the catalyst to change the soluble protein strands fibrinogen into fibrin, which makes this sort of a fishnet, as you will see shortly. That's it. So all roads lead to factor 10. Rome, all roads lead to Rome. You think I should get new material for the next group? Same old SOS, same old stuff. Intrinsic factors are already in the bloodstream. Negatively charged surfaces such as activated platelets make it occur worse, make it occur more rather. Collagen, most common, and don't have a test tube lying around in your butt, but you can simulate it with a test tube. That's why when they take blood out of you, sometimes you want it to clot, sometimes you don't. You know those different colored top tubes, blue top tubes, purple top tubes. Like a red top tube, you want it to clot. It doesn't have anything in it. Some of them have EDTA, which pulls out the calcium. They all have different things in them, and they're used for specific purposes. Because normally, if you put the blood in there, it's good. So the extrinsic pathway, because the key factor is called tissue factor, okay, also called factor 3. It's funny, we used to call it factor 2, but they changed these things, bypasses several steps. Here it is. You don't have to know it, just have to understand it. One step, cut yourself, scraped yourself, whatever. Okay? An injury of enough significance in the presence of calcium, which is in your bloodstream. Factor 7, which is going to be in your bloodstream eventually. Okay? Effectively, that will create this complex of tissue factor with activated factor 7, and that effectively will activate 10. And activated factor 10 will effectively, in the presence of activated factor 5, make prothrombin activator. Unless you're going to medical school, you probably don't have to remember this. And like, unless you're going to be a hematologist, if you're doing a hematology residency, then you really have to know it. Like I did a very comprehensive workup for my first wife when they did the von Willebrands. She was at the blood bank and getting tests, gazillion tests, to see specifically what the problem was. Here's the intrinsic pathway. Note the steps and some familiar names. So we start with activating factor 12. And notice the activation of factor 12 by this intrinsic pathway, whether it's providing the platelets clinging, the chemicals they release, activate 12 to 12 activated, which catalyzes 11 to 11 activated, which catalyzes 9 in the presence of calcium, to 9 activated, which catalyzes 8 to 8 activated, and then the activated forms of 9 and 8, that's right, activate 10. A whole bunch of steps. It's on this side of the equation where we become familiar with those genetically based diseases that we typically refer to as clotting problems that are there. Okay? So we're going to look at clotting disorders as well here from a clinical standpoint. But for years, we didn't have a lot of ways to deal with these things. Again, these factors are effectively proteins, and so or polypeptides, and we can make them. So it's a whole lot different ball game today than it was. I mean, in the old days, this was most of these will study these. I'm sure you covered them in genetics, right? Factor 8 deficiency, factor 9 hemophilia. Briefly, what was Dr. Hill would have gone break?
No, I mean, you just didn't go super in depth.
Oh, my goodness. You didn't talk about the crown heads of Europe? Queen Victoria. Remember her?
I've heard of her.
Oh, thank God. She's the great, great, great grandmother of the current king. I'm an Anglophile. I'm all into that. Did you ever watch the show The Crown that was on Netflix? Oh, love it. They are. That's a very interesting dynamic for those people. I wouldn't. I mean, they're different. So, prothrombin activator, prothrombin makes thrombin. Here it is. So that's the whole ball game, and that whole the activated factor 10 effectively after another couple of steps would happen very quickly will convert prothrombin to thrombin. So the common pathway, thrombin converts soluble fibrinogen to fibrin. The strands are the basis of the clot. It becomes a trap, okay, and it traps not just platelets but all the formed elements, okay. And then we have a stabilizing factor, factor 13, which strengthens the clot. I mean, again, watching yourself heal. Anticoagulants, factors that normally dominate in blood to inhibit coagulation. So they're normally there. That's like the role of the nitric oxide, the prostacyclins, to be able to keep things flowing properly. And so the whole idea is that insoluble, and notice the role calcium plays a role. Fibrinogen becomes fibrin, blah, 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 blah. And then we get that cross-linked fibrin mesh. This is the end product. It's happening constantly. And why I say that to you is to understand this is a system that is constantly in place. When somebody has, particularly on the intrinsic side, problems, it can be very significant. I mean, a lot of times we don't realize these until there's a significant problem in and of itself. That's the beauty. Such a great illustration. It's this fishnet of fibrin strands, and here they are trapping red blood cells. So I mean, that's just what happened. A scrape, a cut, anything along those lines. Yeah, sometimes we have to stitch things up for cover, or else they would heal. The healing would be undesirable, take very long, or have cosmetic implications. There's a lot of reasons why you stitch things up, a lot of reasons why you don't. Ah, the good old days. They all have names. You can see where they're mostly produced that are there. That factor 3, the tissue factor, in tissue cells, activating it. Some are already there. The calcium's already in the plasma. Basically, everything else is in the liver, you know, or even you see bone marrow or lung capillaries playing a role. The clots, think in that intrinsic system, it's happening in our blood vessels all the time. Theoretically, if we didn't have some mechanism to break those clots down, your blood would, all those would be useless conduits or passageways. They'd be blocked. So clots have a very limited lifespan. It's a good thing. So they stabilize and remove when the damage has been repaired. Good work. A very useful design. Our old friends actin and myosin contract within 30, 60 minutes. They squeeze the serum, which is the liquid. Serum is plasma minus the clotting factors. Okay, it's without the fibrinogen and the clotting factors. That's what we used to use serum glucose rather than blood glucose. So those were the old tests. That's why they used to let the blood clot. Serum is the plasma minus the clotting proteins, draws the ruptured blood vessels and edges together. So it's important for that's part of the maturation of a clot. The vessel begins to heal even as it retracts. That's your friend, platelet-derived growth factor. Stimulates smooth muscles, stimulates fibroblasts. That's why it's so useful. And if you can think of wounds healing, it stimulates the margins of the wounds, even if they go pretty deeply. They're there. If it gets down to, if you think under the skin, if it gets down to the dense, irregular, the deep dermis, it's not going to make that. That's going to heal with scar tissue. But it's going to heal the overlying area. It's going to increase their healing. That's what wound healing. I was working with a wound healing guy 50 years ago. I was at a wound healing clinic before they had a name for that type of stuff, using very advanced mechanisms. It was mostly for people with sickle cell ulcerations. I was watching them there, and decubitus ulcerations, which are rampant in people who are quadriplegics and paraplegics. The Vets Hospital I worked at in Richmond, I don't know if it's still the case, had the second largest spinal cord unit in the United States. The largest one was in LA. There's an old movie, brilliant, called Coming Home. And that is with Jane Fonda and Angelina Jolie's dead. His name will come to me. Okay? And that was a brilliant movie. They were the ones. It's funny that got almost more awards than Godfather 2, which really was really the best sequel in the modern era that I could think of offhand. Nevertheless, that took place in that L.A. thing. It was really interesting. There were a lot of movies about post Vietnam veterans, so I encountered a lot of these were Vietnam and Korea veterans. Very interesting to watch how they dressed and changed those alterations. So I got. Sometimes you do things, and this is a good thing for you going forward in your careers. I know I'm being preachy. I didn't get any credit for that for these 2 months there. I did. We had to pay for it out of pocket by living expenses. Thank you, Dad. Okay, I had wonderful mentors there. All I did was spend 2 months sucking up knowledge. I was just like with brilliant people and just picking their brains. Very helpful. They were so good. So here's vascular endothelial growth factor. This is part of it. So these are, I mean, it's one growth factor will trigger the other. So now we got to get rid of the clot. So clots are removed after repair is completed 2 days from the clot forming. We start to trigger this. It's called plasminogen is a protein. Ogen means it's in the precursor state and it's converted to plasmin. Okay, so there's an activator called TPA, tissue plasminogen activator, factor 12, which is in the bloodstream anyway, and the thrombin itself, which we've activated. So after a delay of approximately 2 days, we activate endogenously the clot busting mechanism, effectively to reopen or recannulate, this fancy term, create these canals or openings in those blood vessels. Years ago, when somebody got a blood clot and you got to it quickly enough, like a heart attack or a stroke, and you could identify what it was, we used to inject streptokinase. That's an enzyme that we harvested from Streptococcus pyogenes, strep throat strep. Streptococcus pyogenes spreads very easily. That enzyme breaks down clots and obstacles. The trouble was, you're injecting something that could have significant responses to, allergic responses to, or adverse responses to. But opposed to somebody be dying from a stroke or a heart attack, desirable. We now make genetically, here we come again, and I forget the name of it, it's called TPA. Uh, one of the more recent episodes of The Pit, they injected it. You have to look up the name that it goes under, the generic name. They injected because the lady was diabetic and developed blindness in one eye, and they just injected it. She's starting to respond to it in the episode that was last aired on Thursday. And effectively, that's what they inject now. So most hospitals, certainly trauma centers or hospitals where you have a lot of people who are subject to strokes and heart attacks. So if you go down to God's little waiting room, Florida, I'm saying it in jest, but it's absolutely true. My aunt was living down in East Coast Florida. I'm thinking somewhere between Lauderdale and Palm, and she had a stroke. Whatever, she had symptoms. Fortunately, whoever was there, whatever facility she was living in, it wasn't a nursing home or anything like that. Somebody was coming in and checking on them, which they do a lot with these living situations, retirement. Got her to the hospital. They injected her. She recovered. She lived many years after that. Surely 5+ years. Because, and look, that's an area where they see that stuff a lot. Okay. So there's a lot of interesting things. 2 mechanisms limit the size. The clotting factors get moved away. They get inhibited. Limited amount of thrombin is restricted to the clot by fibrin threads, preventing the clot from getting too big or escaping. The big problem with clots, not so much the clots that you and I get from an injury, but the clots that come from damaged blood vessels like this, that's the clots we worry about for traveling. Typically, the ones here are surface. Remember I talked about the anatomy of blood vessels and anatomy for those who are with me. basically on the skin. It's a superficial system. Those clots don't go deep and have the potential to go into your lung. They'll be a pain in the neck, but they're not clots that are going to break off and cause you problems. So antithrombin 3 inactivates on the unbound thrombin that escapes. Heparin and the basophils and mast cells inhibited. Heparin, when you put an indwelling thing, we just call it a heparin lock. So you had a catheter, capped it. If you had to use it again, you got a little bit of heparin in a syringe, flushed it. That would take any little clots that had formed, and you'd inject the medicine or start the IV. Basically, it was a line that was there that you could use X amount of times fairly easily. So we used to call them heparin locks. If they're doing that, I do not know. Again, what's the right word? The disclaimer is I haven't worked in a hospital in 25 plus years. So who knows what they're doing? Maybe magic. So factors that prevent platelets, the lining, the antithrombic substances, nitric oxide, prostacyclin is the prostaglandin in case, vitamin E, that's why you have to stop taking it. Those neat little vitamin E and vitamin D capsules, got to stay away from preoperatively. These are when we talk about, and that's the rest of this chapter, thromboembolic disorders. What that means are things that can cause you undesirable clots to form. A thrombus is a clot. An embolus is a clot or part thereof that has broken off and traveled. You form thrombi, but when they move from a location either totally or in part, then they are called emboli. So collectively, we talk about thromboembolic diseases. And those wonderful support stockings that they put you on in the hospital, if you got to be in there for a long time, TED host thromboembolic disease holds. We talked about that a little bit when we talked about veins. Remember, I'm into veins as an art form. That was my research area. So I remember me being in, I spent the better part of a short 3 days, about 3 or 4 weeks in the hospital, preoperatively and postoperatively back in 2000, under 50 years old. And the squeezers were on there, those intermittent compression devices. That's to keep things moving, not in the superficial area, but in the deep area. Most of the clots come from here, up in the calf. They're called the soleal sinusoids. Gastrocnemius is superficial muscles, medial and lateral. Underneath it deep is this immensely thick muscle called the soleus. Together they form, their tendon is the Achilles tendon, and inserts into the calcaneus. Oh boy. So I look back and studied the original research on the clots and where they formed. That was done in the 50s and stuff like that. And, did a paper on that, presentation on that. So, bleeding disorders, etc. DIC is both. Very interesting. I'll get into it a little bit. Thrombus, the clot that develops, may block circulation. I mean, when a diabetic gets gangrene, it doesn't involve an infection. It's typically a clogged artery that's going on. And then there's, relatively speaking, a lack of oxygen, and it doesn't take much for their tissue to die. Embolus is a thrombus or part thereof. So embolism technically is the same thing. Now it's obstructed something. Remember, anatomically, they typically start in veins, the thromboembolic disease ones, like I was talking about, and where the vessels get larger as they go to the heart, but they get smaller when they go through the heart and in the pulmonary vessels and start leading to the lung. That's sort of their pathway, typically. When we see one of these where it leads to tissue death, that's typically arterial. Often they come from heart valves, because the irregularity of the heart valves creates turbulence, and that can form clots because of it. As well as people have have vascular disease that's ongoing. So none of you have to, I dare say nobody here, none of my students have ever had to worry about it. But you all have relatives who are like my age and are diabetics or significantly overweight and have bad. I mean, I'm not telling you to get preachy. It's something about old dogs and new tricks applies. I love these little sayings, but it's absolutely true. So the way I would frame it, here's what we learned about in advanced physiology. All of this stuff, maybe it'll I hate the term, resonate with them. All I can think of is Dr. Badger Lester when he's talking about resonate. And people love that word. Does that resonate with you? I want to get a tuning fork and go, bing. Stop. Oh, that resonated with me. Oh, shut up. Can you just say it was important? All the risk factors that are there. The big one in the hospital, and why they get people out of bed quickly, why they get people up and walking about, why they get them down to physical therapy, why they don't stay in hospitals very long. You say, you're not doing it, you're sitting in bed. Not a good thing. Anticoagulant drugs, aspirin, inhibits that thromboxane. And that's the idea. That's where it came from, that baby aspirin a day. There are other agents that are nowadays where you have a lot of agents that don't have side effects. Aspirin can damage the GI lining. There's a whole category of agents today that actually make the red cells a little more bendable, and they can slide through those little nooks and crannies. So they don't jam up and initiate the clotting to nearly the degree. Heparin, it's hospital, it's injectable. Okay, all of those things. Warfarin, this is the problem. Years ago, the primary method for home was an oral agent called warfarins. Okay, they are oral, and the trouble is, and again, a lot of these things, AFib, which generates a lot of clotting, we're going to get to that next. When we start to talk of the heart, and I'll introduce that rather than drone on. Yeah, I'm going to call it at least a half an hour. Can you handle another half an hour? I can see the enthusiasm. If Jenna can tolerate it, you promise you're not going to fall asleep.
I don't do that.
You don't promise, or you don't fall asleep.
I don't fall asleep.
Right. You're just resting your eyes.
Yeah. But I don't promise anything either.
Good. This is what you use, and you see a lot of those commercials on TV. This is fine for blah, 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 blah. But if you have atrial fib, you have ask your doctor, blah, blah, blah. All those disclaimers. That's the insurance company telling them all that stuff. And by and large, it basically deals with vitamin K. If you work, particularly in long-term care, these are still used a lot. And they do a thing called INR. That's an international ratio, is what it stands for. It's the test, and this is one of the tests they used to do. It's called a pro time or prothrombin time. It has to do with when you have a patient on this, if their normal prothrombin time was 12 seconds, therapeutically they had to be at 18 seconds, 1.5 times. And about every other day you would do this in a nursing home because a ton of those people were on that. Like I said, I do not know if that's still used. My wife did nursing home care, both as an aide and as an LPN for 10 years. They did a ton of those. A ton. So you had to call the doctor and see it, or the PA, and say, do we need to adjust the medicine, blah, blah, blah. So for those of you, I assume they still use that. And for some of you interested in PA type stuff, that's the kind of thing you're probably going to need to be familiar with. Thrombocytopenia, not having enough platelets. A lot of these are genetically based disorders, and what we see with these people, it's almost like they have an excessive amount of reddish freckles, except they're not freckles, they're not pigmented lesions. This is blood under the skin. So petechiae are tiny and pinpoint. When they're larger and big blobs, we call them purpura, P-U-R-A. It's funny. In medical science, we have names based on size. So petechiae are tiny, purpura are larger, and then there's another term for all over the place. So petechiae, widespread hemorrhage, and there's a lot of things that can do it. So, this is what you think about. Why are there not enough platelets? Is there something going on in the bone marrow? Is it a reaction to medication? Is is there an underlying tumor? Is the patient been exposed or is receiving radiation therapy? Remember that platelet count. I mean, 150, anything under 150 was low. Under 50, whoa. So thrombocytes, clotting cells, penia, a lack of, is where the derivation of that name. And this is where platelet transfusions came from. That's what typical petechiae look like. I mean, I've seen many, many cases with purpura all over the same area. That was an allergic response. It triggered a lot of histamine release in mast cells and particularly targeted the lower extremity. I mean, it's got a great name. You don't have to know it. It's called Henoch-Schoenlein's purpura. That was one of those things. Those were board exam questions. When you take medical boards, not only do you have to answer them the way and that's why I do all these objective questions. Board exams are objective. You're not writing any essays. Let me write an essay. I'll tell you what I know. Don't work that way. The other thing is practical. And what they'll do is they'll give you a case to study. And they'll basically walk you through this. A 37-year-old female presented to the dermatology clinic with a blank, blank, blank. Okay, they'll show you a picture. Okay, they'll give you some history. What is your differential diagnosis? What are 5 or 6 things? And there's typically 4 or 5 things, and you have to get 4 out of the 5 or 5 out of the 6. That's what allows you to pass the test. And the next thing they'll go to, okay, what test did you order? Same deal, 5 out of 6. Then they'll go to, based on this test, what do you come with as your diagnosis? You got to get that, then you got to go on. Remember my orthopedic boards, I just missed one that had to do with, it was like an very odd condition called multiple enchondromatosis. And I got right to the differential, and I picked the other one, which was multiple metastases. I remember it to this day. The only thing I got wrong on my orthopedic boards. Still made it out. Be that student. Be that. Liver function, because all they come from there. Vitamin K, liver diseases, all of those things are part of it. Okay, this is all. So your liver is your blood, your friend. And here are the disorders. Hemophilia A, most common. That's the one. That's the factor VIII deficiency. B is a little less severe, as is C. So B, 9, 11. This is the one I was asking about. So it's how is it transferred? Is it sex-linked? Is it autosomal dominant? I wonder if it's sex-linked recessive.
You know what? Now that I'm looking at this slide, for whatever reason, I do remember seeing a pedigree of like the royal family.
Aha!
Yeah, I remember that.
Queen Victoria happened to harbor this. I don't know where she got it from. Maybe, George the whatever, like George the Third or George the Fourth was frisky. I don't know. You got to watch out. They're pretty frisky. Well, Prince Charles is married to Queen Camilla now, and they were always an item. Camilla's husband at the time, they didn't. They were, to say it was an open marriage was probably minimizing it. In the early days, Princess Anne, King Charles' younger sister, she was frisky with him. They were having a shag-a-thon. You're not interested in this. A little bit of history won't hurt you. Okay. Queen Victoria had 8 children, all of whom carried this. And in those days, royalty married royalty. And so they married. It was to cement trade relations. It was basically you married royalty. And so the crown heads of Europe, many of them carried this disorder. And most notably, in the Russian Revolution in 1917, the last Tsar, and that was the whole thing with Rasputin. Is this history familiar to you? No? Rasputin was this monk who seemed to have a magical power to calm the screams of the future czar, a child, whose name escapes me. And they were, it doesn't matter, the family was all murdered during the Russian Revolution. It was called the House of Special Purpose, Stalingrad area. And what happened was this Rasputin had this ability to calm this child. The bleeding was so bad into joints that they would expand and the pain was intolerable. He couldn't wait there. They had to carry him everywhere. So that's, I mean, so it affected a lot of people. That was, and that is by far and away the most common type. So now we have the factors. We can genetically engineer them. We don't have to use transfusions, and the risk for these hepatitis C and HIV significantly minimized. It was a horrible, horrible disease. So there was really very, very limited treatment up until I would dare say the last 20 to 25 years when really this stuff became available. DIC, disseminated intravascular coagulation, is very unique. And so what it does is it gobbles up the clotting factors. And so offensively it starts these agents. So typically when you would see this is gram-negative sepsis. Also blood transfusions, amniotic fluid getting into the bloodstream will trigger it. The most common, a wonderful dog of ours got this. He had a tumor in his abdomen. It finally broke, and basically he had, because the gram negatives that are in your, your alimentary canal got into his bloodstream, and he basically succumbed to this. And what happened, which is that phenomenon, and what happens is initially it causes all this clotting, then it gobbles up the clotting factors in the process of doing it. So you have both clotting and bleeding going on simultaneously. It's almost impossible. If somebody gets it widespread, they're likely not going to recover. So severe bleeding follows because you can't clot. So, and this is really a significant thing. So, and this is, I mean, you're again, transfusions are useful, but you can only deal with so much. Okay. So, I mean, and again, this is the way we framed it when I started talking about transfusions. The sudden blood loss of a third of your blood is most likely going to be fatal, unless you get to emergency room right away. Again, I gave you the information from me. If it's done on a chronic basis, a little at a time, that's why I'm still here, to torment you. So thank God that ends the blood. Oh, thank goodness. Are you still out there in virtual land? Good. Moving on. If you remember, we did the heart anatomy. If you weren't here for that, review the heart anatomy. This is heart physiology. I just wanted to review what's going on in the heart electrically before we get into the pure physiology. Okay? I heard that. That means you're still here. Oh, good. They still like me. I died. Why did I even talk to me? Oh, Lord help me. We looked a little bit at this. Electrical events precede. Many of you were there when Dr. Buxton came in with his photographing physics. And we did a little EKG stuff. This is where it comes from. Electrical events precede mechanical events. Really important. We see a lot of this here. And yes, the autonomic nervous system, fight or flight can accelerate it. Vagal tone can decelerate it. We know that. Okay. It's about gap junctions for sure. But we want to look at the conducting system. Again, the heart has structural cells, the framework, the valves are on it, the vessels are anchored, the valves are anchored. It has the vast majority of the heart is the muscular layer, myocardium, and the difference between those cells are contractile They have cells that are similar but don't contract. That is basically the conduction system. We identify it by 5 locations that are there. Non-contractile, many of them, at least 3 sets, are autorhythmic. They're sufficiently leaky that they don't stay. Remember, we talked all about this resting membrane potential. When they reach resting, they start to leak. Okay, sodium leaks in, and it begins to go to threshold at a predictable rate most of the time, and that sets them to fire and sends the impulse. If it works right, it's great. If it doesn't work right, big trouble. So they're autorhythmic. They initiate and distribute impulses, and they coordinate the polarization and contraction of the heart. Remember, a two-sided pump with an upper and a lower chamber. They work at the same time. One's pumping it, the pulmonary circuit, to basically slow a low pressure system, even though it's pumping out the same volume to make sure it's oxygenated. The systemic circuit, much more powerfully pushed out. That's the left side. You get the blood all the way around and distributed, and the impetus to bring it back so we can do it all over again. 2 chambers. The upper chambers are basically filling chambers. Very little in them. They're very small. Except that they basically, when the heart starts to contract and the system becomes activated, it tops off the tank. 80% is filled passively. The last 20% actively. That's what happens, as you're going to see when we have the atria contract. After that, when the ventricles contract, very rapid. Blood is pushed out very, very, very rapidly. Not all of it. We're going to look at something called ejection fraction. It may surprise you that each chamber only holds 4 ounces, roughly, about 120 milliliters. The top off is, whatever that turns out to be, 20, 25 milliliters, less than an ounce. To top that off, that 20%, that's part of it. You can do the math. What's interesting is we only eject 57%. That is a good ejection fraction. We look at that a lot to make sure the heart is functioning properly. If it's off at all, if one side is stronger than the other, it's all about being equal. Any mess ups on that, it's going to go, you're going to have unequal flow, and eventually it's doomed to, and here's the word, failure. There's lots of things, but this miraculous structure that beats more rapidly, here I go again, more rapidly than once a second, every second of our lifetime. Which is why I am now getting to the gym on that trip. Just like the headphones are. Thank God it's noisy enough at Planet Fitness they don't hear me. See you. Gap junctions. Gap junctions are sort of the key of sending the signal along, or intentionally delaying the signal if needed. Get onto that. So, non-contractile, initiate and distribute. They have an unstable resting membrane potential. We call it a pacemaker potential. Okay? Potassium channels are closed, but the slow sodium channels stay open. Okay? The action potential, calcium channels are really this is unusual. It's a little different. At depolarization, calcium channels open. Once it gets, shortly after, we begin the depolarization, and that leads to a rising of the action potential, and you're going to see it's much more prolonged. It's not like a nerve or a muscle twitch. And repolarization of potassium channels open, and then it'll return. So this is look at what it looks like. So here's the resting potential, and all because of the sodium channels, it brings it up to threshold approximately, in this illustration, about 40. At that point, the calcium channels open. Look at how wide that is. So it's a prolonged depolarization. It's not that sharp spike. we're used to seeing. And then as it goes down, okay, we just start the whole process again. So the calcium is responsible here, potassium here, sodium here. And you can see they illustrate it for you. Sodium channels open, calcium influx, and then repolarization, calcium channels inactivate, potassium channels open. The five structures: the SA node, the AV node, and the subendocardial conducting network, which I grew up on calling Purkinje fibers, and a lot of people still do, all have pacemaker potential. The only one that really is useful to be really function normally is the SA node. That whole thing takes less than a quarter of a second. In about a quarter of a second, your heart basically everything it does, everything it needs to do. Okay. The rest of the time, it rests. This is when we're going to talk about absolute refractory period. Those inactivation gates are really significant because the heart rests for a minimum of a quarter of a second. Optimally, much longer. And why it's optimal? Because that's your cardiac reserve. That's the whole thing with aerobic activity. That's why you can calculate. I have an idea what my target heart rate is. I have to be on the treadmill for 30 minutes at that target rate, blah, 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 blah. It's based on, physical condition plays a role, but age is really the major criteria. Thankfully, I don't have to get my heart rate up as high as I used to. But you guys do. So the SA node to the AV node to the AV bundle, which is a thin strip, the only connector between the atria and the ventricles, and then they branch right and left. And effectively, that signal travels very, very rapidly to the apex of the heart and goes around it like this and like this, side to side, front and back, very rapidly. And remember that illustration where remember the blood is squeezed sort of from the bottom up, if you want to think of it that way. That's so important. That's how we eject the blood. That's the magnificent relationship between form and function, anatomy and physiology. Look at the heart. Look at the way the muscles are arranged that are there. The pacemaker is in the right atrial wall. Why is it the pacemaker? It's the one that basically depolarizes fastest. Average time, we call that a sinus rhythm. Usually for most of us between 60 and 80 beats per minute, depending on how healthy you are. Again, we talked about this. The vagus nerve keeps it because the rhythm would be greater than 100 times a minute. You might recall what I said to you before when I didn't go to the gym. I ate whatever I wanted. Thankfully, I didn't drink and smoke 2 packs of cigarettes a day. I remember testing it. It was like 106. Yet I'm here. Now it's much better. I always test it after the class. Usually goes up pretty high from stress. So the impulse spreads from the atria to the AV node. At the AV node, the inferior interatrial septum. This is the slow point. It's slow because it has less of those, basically, the ability to transmit it. It has fewer gap junctions. The fibers are smaller. This is by design. It's not an accident. That's what allows the muscles that contract not necessarily as strongly to effectively cause the atria to push that last 20% in to optimally fill the ventricles. The whole idea is you've got to be equal and you've got to do it so that each time the heart is filled to the appropriate level. And that slows it down enough so the atria can contract most efficiently, because once it gets through that AV node, and as you can see, it has a rate all of its own. If somebody through a heart attack, through some defect, has lost this, we call this a nodal rhythm or a junctional rhythm. And at 50 beats per minute, you can survive. You can't do very much. It'll be a hard time moving around. hard time doing much activity. And when people have this, that's when we introduce pacemakers, which connect the atria and the ventricles, because really the ability for this signal to pass. And I mean, pacemaker technology is infinitely better. There are still some limitations. They have to be implanted. There's all sorts of interesting nuances to them. What they are today, modern, but effectively they have to put an electrode in the atria and an electrode in the ventricles, and the device is not only going to make the atria contract, it's going to make sure the signal gets appropriately to the ventricles. Just the way it has to work. Medicines, cardiac medicines are fairly harsh, particularly for arrhythmias and things like that. That's where they stopped using them when people had that. Okay. To the end, the bundle again is the only connection. Known as historically as a bundle of His, that's a proper name. Right and left bundle branches carry the impulse toward the apex, and then the last one of these has its own rhythm, about 30 beats per minute. Can't sustain life. Eventually, not enough blood is going to flow. The patient's going to go into VFib, which we'll look at next time. We'll talk about these different arrhythmias, and we'll probably do the lab electric, with the technology, so you can. And this time we'll get volunteers, or else maybe we'll get somebody to drink down an energy drink, do it before and after. Guzzle a Red Bull. No Red Bull with extra helpers, whatever drink that is. I don't know what it is. It's not like my daughter's Captain and Diet Coke. Don't, I see you. You saw her. She's a partier. Way back. So, only electrical conditioned. Now we have the bundle branches. Here, more elaborate on the left. It has to be much more muscular. They have their own rhythm. They contract immediately. They're so rapid. And that's what we look for. We measure the times. And I'm going to show you, I have some pretty good information on where the times are, how to interpret electrocardiograms. I'm going to have, even from an exam perspective, you'll get some of that. It doesn't take very long. It's a very good illustration that you can see here and read through that. And this is it. We're going to look at arrhythmias, irregular rhythms, things that don't allow for proper coordination. They are a big problem. It's not unusual to have somebody who occasionally skips a beat. A lot of times that's just something people have, and it's not pathogenic, particularly if it's a comparatively random event. I mean, my wife said that when she was doing, but we appear to take my blood pressure and my pulse, and she'll go, fine. Oh, I just had it. Not that it doesn't happen at a regular interval. It just sometimes they skip. And we'll talk about the different arrhythmias. Particularly the worst one is called fibrillation, where it just doesn't work properly. I think this would be a good time to say bye. My voice is going to give up. So I'll see everybody Wednesday for the exam. I mean, there's nobody in the room if you get up there early. I mean, I'm fine. I mean, I know you have, many of you have class next door. Just tell me you're not going. I'll try to get up there by Wednesday. Goodbye. Thank you. Have fun.